Hello, and welcome to our program titled Bridging Distances in PAH, bringing best practices to the people through telemetry. This is segment 1 of a 6-part series. I'm Dr. Nicholas Kolaitis, Assistant Professor of Medicine in the Division of Pulmonary, Critical Care, Allergy, and Sleep Medicine at the University of California, San Francisco. I'm joined today by my esteemed colleague, Dr. Jean Elwing, Professor of Medicine in the Division of Pulmonary, Critical Care, and Sleep Medicine at the University of Cincinnati in Cincinnati, Ohio. Our disclosures are displayed on the screen. This educational activity is supported by an independent educational grant from both Merck, Sharp, and Dohme, LLC, and Actelion Pharmaceuticals, US, a Janssen pharmaceutical company of Johnson & Johnson. The learning objectives for today's program are to integrate telehealth and telementoring practices, to ensure consistent remote access to specialized multidisciplinary teams for optimal care of PAH patients, and to summarize best practices for decreasing the diagnostic interval in PAH. Dr. Elwing, would you like to start off our conversation today by summarizing what clinicians need to know about delayed diagnoses in PAH?
Oh, thank you, Nick. Thank you for asking that. A very important question, and thank you for inviting me to share this conversation with you. So we know that pulmonary arterial hypertension is a progressive disease and it is not cured. We do, however, have many treatments that have more than doubled survival in our patients, now reaching 10 to 15 years. But it's still high risk, and they still face poor prognosis, especially when the diagnosis is delayed. So I'd like to talk to you a little bit about that because I think it's such an important thing people be aware of, that our patients go through multiple visits, on average 5 primary care physician visits and 3 specialist visits before they reach their diagnosis. And that takes over 2 years in many of our patients to reach that final diagnosis of pulmonary arterial hypertension. And they're treated for other conditions during that time, which delays the time to getting the right management.
Thank you, Dr. Elwing. I'm now going to discuss some of the challenges in diagnosing PAH, because once we understand the challenges, we can understand where we need to act to change practice. As you know, patients with pulmonary arterial hypertension often present with very nonspecific symptoms. They might present with insidious onset dyspnea and fatigue, but more of the advanced findings that we associate with pulmonary arterial hypertension, such as chest pain or syncope or fluid retention, don't occur until patients are at significant risk of death due to very advanced disease. And early on, our patients may present with just shortness of breath of unclear etiology, which leads to a diagnostic challenge because pulmonary arterial hypertension is such a rare disease that many frontline providers don't think of it in their differential when a patient presents with dyspnea. Another challenge that we're faced with is that many patients live very far away from accredited centers or centers of excellence who know how to manage patients with pulmonary arterial hypertension. Take, for example, a patient that lives in rural Montana, and their nearest center is Salt Lake City. That means that they're over 550 miles driving away from the center of excellence, which is over 9 hours. And so these PAH care center deserts leads to a further delay in diagnosis because the frontline providers and the community, the medical community in some of these places, doesn't have an awareness of the existence or of the importance of diagnosing pulmonary arterial hypertension early. In addition to that, many patients with PAH face multiple issues related to social determinants of health. As we talked about, distance from a center is an important thing. Care in these centers is highly specialized, and if patients have transportation issues, this could lead to delayed diagnosis because they don't end up coming to the center due to these transportation issues. Medical literacy is really important, not only in our diagnosis, but in our care for these patients, because some of our therapies are very complex and hard to tolerate. Housing and access to reliable refrigeration is important for some of our patients because some of our meds need to be refrigerated. The cost of treatment, it can be quite burdensome from patients. And so financial resources impacts how care is delivered. Additionally, the diagnosis of pulmonary hypertension is associated with loss of ability to work, and so income can be affected and mental health can be affected as well. So all these different factors come together and they can delay diagnosis, they can delay treatment, and they can impact our care in these patients. Dr. Elwing, I want to talk about the geographic barriers that we have present.
So one thing that has come about in the recent several years is the use of telehealth. And telehealth has its strengths and its weaknesses, but the one place I think has a great role is reaching our patients that are having difficulty finding us and traveling to us. And there's many advantages that I'd like to point out. One is it's cost savings for our patients. They have less costs with driving, taking care of their vehicle, staying overnight at a facility that may be quite expensive for them. So that's one. Second is quality. We love our primary care providers, but our patients that have PAH need to see a specialist that focuses on this illness because it is so very complicated. And it's one way they can improve their quality of care by having that backbone of their primary care physician, but adding a specialist in that may only be accessed in some occasions virtually. And more timely appointments, earlier diagnosis. We talked about the delay in diagnosis that is real and ongoing in our patients. Anything we can do to reach patients earlier, we want to do. And we can reach patients earlier if we can go through means of virtual visits to discuss with them, evaluate, and get that diagnosis secured more quickly. And education. We have a lot of ways we can reach people virtually, and we can utilize that for our PAH patients to teach them about disease, teach others about this disease, and support them through virtual support groups. And through all of these efforts, we can personalize their care. If some people need more attention to titration of medications or follow up of their heart failure, we can do that because we have that way to touch patients more easily through this virtual means. So we hope adding this all together gives us better outcomes. Do you agree with that, Nick?
I agree completely. And I think that was a great recap of where we are with telemedicine and how it can help our patients. I really want to thank you, Dr. Elwing, for your thoughtful commentary today and for your insight on the impact of delayed diagnosis in PAH and how we may overcome geographic barriers when managing these patients. In summary, what we discussed today is that delayed diagnosis predicts more severe poor outcomes in patients with PAH. That the diagnosis in PAH is challenging due to nonspecific symptoms, and also because many patients live far from accredited pulmonary hypertension centers, leading to PAH care deserts. Many patients with PAH also face negative social determinants of health that reduce their ability to access accredited centers. Telehealth and telementoring might help us overcome some of these geographic disparities and other barriers to care. This is segment 1 of a 6-part series. Please follow Iridium CE on X, Facebook, and LinkedIn so you will not miss any updates.